All right, it looks like we're rolling. Hello, everyone, and welcome to the Heartland Daily Podcast, where this week we're going to be talking, or this show, we're going to be talking about healthcare policy items and what's going on in the news. Many things happening in the healthcare world. My name is AnneMarie Schieber, and I'm the managing editor of Healthcare News, and I'm joined by Devon Herrick, who is a healthcare economist and a contributor to the Goodman Institute's Healthcare Blog. Good to see you again, Devon.
Good to see you.
Hope you're staying cool there in Texas. Actually, I think it's warmer every place else. We have a lot. Good. We've got a lot coming up today. We're going to talk about 5 things and just actions that have happened over the last couple of days, at least anyway. One involving organ transplants. We're going to talk about home births for Medicaid moms. Hormone replacement therapy, which is getting a lot of attention. Martin Makary, who's the FDA Commissioner, has talked about this in his recent book, and it's not surprising that it's crossing the radar right now. Still, of course, the one big beautiful bill and what's coming down the pike regarding Medicaid and trying to get those costs in line. We have action to try to repeal some of those cost cuts, and we'll talk about that. What level of privacy you have when you sign up for a government healthcare program. That's also on our agenda. And then lastly, we're going to wrap it up with what their vocation truly is. Is it a calling or a job? Has it changed over the years, and why that should concern all of us? All right, so let's start out on the top. This was a couple of weeks ago, July 21st, and Robert Kennedy, Secretary Kennedy, announced a new initiative to crack down on the organ transplant system. And there have been escalating reports of people who have been declared brain dead and being wheeled down to emergency room surgical centers to have their vital organs removed and transplanted into somebody else. And of course, they don't survive that procedure. And so this has become very controversial. And what I was surprised, first of all, that it's getting the attention of Health and Human Services, our secretary. But a report came out. And there was a very famous case a couple of years ago involving a young man in Kentucky. And I think he had a drug overdose or something, but he was declared brain dead. And he was being wheeled down the hall to remove his organs. And then he woke up. And his name, I want to pull up his name here because it's all over the news. It's Anthony Thomas Hoover. And this was in 2021. And he woke up on the gurney, thrashing and crying 1 hour before this procedure was about to take place. And of course, it did make the news. Kentucky Attorney General Russell Coleman is investigating. And then the Biden administration, this happened during the Biden administration, there was an investigation and then it was dropped. No charges, nothing happened. So Kennedy got wind of this and he reopened, he ordered the transplant organization to reopen the investigation and prove that they are taking action, that this will never happen again. The one thing that they found that they opened, the letter that he presented in this news conference, was that they found 351 cases where organ donation was scheduled but not completed for whatever reason. And about 30% of those showed concerning features, including 73 patients with neurological signs incompatible with organ donation. And 28 patients may not have been deceased at the time of organ procurement. Now, I should mention, few people realize what happens. A lot of these decisions are made in very tragic circumstances. They involve often young people who are in crashes, some kind of emergency, drug overdose, or whatever. And the families are dealing with new information at them, and they may be told by the hospital that their loved one will never have a normal life, that they are brain dead. And when you donate an organ, like a heart or a lung, the organ has to be very viable for it to be transplanted successfully into another body. There has to be some sort of blood flow into the organ, and they do it very quickly. And so there is a big debate of really how deceased the donors really are. And this diagnosis called brain death has emerged over the years, and it seems like they might be cutting corners and just, there might be some hope for recovery, and they're making these decisions at the last minute and appealing to the sympathies of the family who may not understand the possibilities here. And a lot of people are not given information. So, and I should mention that the organ transplant industry is a very lucrative one. There was a company, a consulting firm called Millman, and they did a survey recently and found heart transplants generate $1.6 million in billable charges to the transplant center. So it's big business. And I think it's very encouraging that this is getting the attention at the national level. Are you familiar with this, Devon, and heard what's going on?
I mean, the transplant industry is, I've been critical of it for many years. And in fact, a lot of people are critical of it because it's not managed well. But that's not my complaint. My complaint is everybody, all the stakeholders involved make money except the owner of the organs or their heirs.
Oh, yeah.
And so you talk about it being lucrative. Well, oftentimes they don't really involve the family too much. They, can you, they of course appeal to, would you be an organ donor? But it's in dire need of reform, and it's not just cost cutting or cutting corners. It's very opaque, and essentially federal law says that if your loved one, your father or what have you, is dying and they know he's dying, the hospital comes and say, would you allow your father to be an organ donor? They don't offer you $10,000 in cash, even though they're going to make tens and tens. And of course, the organ procurement organizations, every time it's discussed, allow a little bit of compensation. Oh no, that wouldn't be prudent. That's not appropriate. That's not ethical, because they get all the money.
Right.
But the reason why are organs scarce? They're scarce because nobody makes money off the issue. The owner of the organs or their heirs cannot benefit any way. Just the healthcare establishment and the procurement organizations, and it's really, and it causes more death than it saves, simply because organs are now very scarce because of that.
Well, I would encourage our listeners to go onto Healthcare News at the Heartland Institute's website and look up our articles on this. There is a book. We interviewed her for a recent article, Heidi Klessig. She is a retired anesthesiologist and really got involved in this decades ago when she was training to be a doctor, and she saw what was taking place. And she ended up devoting the rest of her life really basically bringing up these issues and talking about them. Very disturbing history of what's happened over the years with them changing the definition of what death is. And there's also a question, it may not even just involve brain death, but circulatory death, because now we can resuscitate people sometimes more than the 2 to 4 minutes that we generally assume they're dead. And so, do families know this? Again, you're in an emergency situation. There's a lot of emotion, and people are making decisions with very little information. And another thing that people don't realize is, you check it off on the back of your driver's license. The rules have gotten so liberalized now that even if you don't check that off and something happens to you and you're in the hospital and there's no family member standing up for you, the hospital could have the right to end your life with nobody making the decision except the hospital and the doctors. And there's a financial incentive for them to end your life when we, talk about $1.6 million. And I think you're right. If there were a financial incentive, I mean, certainly we don't want to be encouraging people to give up their lives, to give out organs to other people. But, it would seem only the fair thing to do, since it's such a lifesaver for many people. The other point I want to make is, because we have put so many eggs in the organ transplant basket, that we've been kind of lax about establishing other kinds of technologies to help people with failing organs, like artificial organs. There is an artificial heart. We haven't had much success with it, but that's because we've become very complacent and relied on donor organs. There's also, we could also come up with other therapies, other things, besides doing something that raises all kinds of ethical concerns. And then there's also the idea of living donation, where you can donate one of your kidneys and still survive that. You wake up, that's perfectly ethical, or even a part of your lung. Not your lung, your liver, and still survive.
Liver, yeah.
So, and that's done with the, informed consent of the donor. And, it just doesn't, is probably could be very life-saving for somebody else. And that's perfectly legitimate. And then there's other organs that people do donate that don't depend on a blood supply, like corneas and skin grafts and things like that. But the vital organs, such as liver, lung, heart, they have to have, you can't just let the person, you can't take those from a cadaver. There has to be some sort of blood flow before they remove those. So again, raising all kinds of questions. I'm glad that Secretary Kennedy is bringing it to light so that families start thinking about this ahead of time. There is a really good book called The Brain Death Fallacy. And if you really want to be knowledgeable about this, again, you just don't know what's going to happen with your family, for your loved ones. If you're planning your estate, you probably want to write this out for directed order or whatever, in case you're incapacitated. So all good information there. All right, let's move on to our next topic, which is an action that happened in Minnesota about a month ago at the last minute. The legislators there passed a bill that encourages home births for Medicaid moms. Now, this sounds pretty benign enough, but home births can be a risky thing. And when moms are on Medicaid, they're probably facing other kinds of stressors in their life, namely housing, or because, to qualify for Medicaid, you have to be quite low income. And a lot of those people are receiving other services. And for a home birth to happen, I've been told that 70%. So let me just talk a little bit about this law. So the law provides incentives for home birth for Medicaid moms. And what they will do is they will reimburse the provider, and that could be a medical doctor or a midwife or a doula, the full rate of a doctor. So that provides an incentive for this industry now to start encouraging Medicaid moms to deliver at home. And then the moms could also get some assistance for their facility by having the birth at home. So, you pay a fee to use the hospital, Medicaid does, but now they're going to turn that money over to the mom. And there you've got an incentive. If a cash-strapped mom thinks, wow, this is great, I'm going to get a check, they may be taking an action that can be kind of risky. You have any thoughts on this, Devon, about the wisdom of encouraging home births for high-risk moms?
Yeah. Oh, yeah. I don't know what prompted this. So it had to be something in Minnesota that, the sponsor must have known someone who was a doula or a midwife. I don't know, but I can think of a lot better ideas. I mean, it'd be a great idea to maybe say we're trying to incentivize giving birth at a birthing center, out of the hospital, but in a qualified facility that is lower cost, good quality. But you're right, a lot of Medicaid, our moms to be on Medicaid are, at risk. They're higher risk, maternity patients than a lot of other people that aren't on Medicaid. And I tried to find it a second ago, but I really couldn't. But I read an article only a couple of weeks ago about a lady that did a home birth. I want to say it was Medicaid, maybe I'm mistaken, but she did a home birth and they had a complication. And the baby was deprived of oxygen. They called the ambulance. Well, it was too late. The kid is alive, but will never be able to live independently. And that's a very costly risk, and that is a risk that will be paid for by Medicaid for the next, 70, 80 years probably. So it doesn't make sense to me that would be a money saver. It would not, and it does not make sense to me that it would be easy logistically. If you have a big, beautiful home, oh yeah, it's probably easy to get enough professionals in your house to do a home birth. But if you're struggling with housing, you may not even have a bedroom or maybe only all you have is a bedroom.
Yeah.
So yeah, I don't understand why they made that push, that a proposal.
Well,
doesn't make sense.
To me, it seems like it's a class of people who are making decisions on people who they just don't fully understand, these legislators. The woman who sponsored this bill was in labor while she was giving a political speech. So, she certainly was assured that she was going to get excellent care and could take that risk. But that's not really the case for moms who might be struggling. The other thing is the state, Minnesota. This is the state where the George Floyd riots developed, and we had all kinds of watchdog organizations now hammering the hospitals for policies they deemed racist. And I think there was a belief that there was racism and that it might be better for these moms to stay at home instead of going into the hospitals. Minnesota, where I'm going to post this article that we have here in a little bit, but a couple of after George Floyd, these hospitals had to undergo all kinds of DEI training to eliminate anything that might be deemed offensive. They put a lot of equity policies into place, and so that might be some of the reason behind pushing through this misguided legislation. We also checked, no other state is doing this. It's just Minnesota. So we shall see what happens. All right, let's move on. Devon, you wrote something interesting this week, something that hasn't really gotten a lot of attention because we've downplayed it over the years, but it's hormone replacement treatment for menopausal women. You almost never hear anything about it. Why don't you tell us why not?
Well, as you mentioned, I think you mentioned earlier, the FDA Commissioner Makary had some information in his recent book about hormone replacement therapy. And the FDA is now making a priority to try to set the record straight, because before roughly about, I think it was in 2002, the Women's Health Initiative came out with a report suggesting that hormone replacement therapy would cause all manner of bad things, dementia, heart attacks, breast cancer, and the like. Well, prior to this report, and I think I said in my blog post that hormone replacement therapy fell by 80%. Well, I was wrong. It was 90% overnight. I read that hormone replacement therapy was either among the most widely prescribed medication or the most widely prescribed medication prior to the report from the Women's Health Initiative. And just overnight, the rates fell about 90%. And it got to the point that if you had especially bad symptoms of menopause, and you went to your doctor and said, I'll take my chances, the odds are your doctor would say no.
Yeah.
And, Makary knew this was bogus. And in fact, a lot over the last, say, 3 or 4 or 5 years, more and more experts have gone back and relooked at the data from the used by the Women's Health Initiative. And it was women that are 30, 40 years older than most menopause, when women going through menopause. And they looked at it, it was, if you really analyze it, it's laughable how, the sky, how they interpreted just a case or two and claimed the sky is falling. And so now increasingly doctors are coming forward and saying, yeah, this was wrong. It was always wrong. We've deprived a whole generation of women who are suffering from the medication that could have helped them based on a few data points that were, that by no means showed extreme risks or even high risk or even moderate risk.
Yeah. I mean, it's interesting. I mean, we give men testosterone if they want it. No question about that. And then I think because it's been so off the radar, you have to start taking this therapy at a certain age for it to have any effectiveness. But Makary, I remember listening to a discussion when his book came out called Blind Spot, and he talks so much about hormone replacement therapy. I mean, it's been linked to reduced dementia, all kinds of senior ailments down the pike, way beyond menopause. And, think about it. It's probably a low-cost way to stave off some of these long-term issues. And to me, it's just stunning. It's almost like they wanted to not see it succeed. And look at all the expensive healthcare conditions that can come down the pike without, the ability for people to take advantage of something that holds some promise. I mean, certainly what we're going to get from Makary is we'll probably get some better studies and more attention to the issue. And I don't even know if health insurance even covers it. Are you familiar with,
I think it does not in many cases. And also what Makary wants to do, and a few others, is remove the black box warning. Currently, there's a for those who do get HRT, there's a warning on the box that basically says it'll cause all manner of extreme issues. And some experts, including Makary, want to remove that warning just because it scares women, that and their loved ones. And so if it's not really, or the risks aren't that, as they're made out to be, just remove the warning and let your doctor and talk to you about, what the risks are, if any, and if you're at higher risk. I mean, I think he's on the right track.
Yeah. I mean, again, and it's all a symptom of highly regulated healthcare where people are not really given the opportunity to make their own decisions. Every single patient is different. And the decision should really come down to what you and your doctor think is best. And when we make these big, warnings about a particular treatment or try to ban it or whatever, we really deny people the opportunity to make their own, to give them healthcare freedom. And this is a perfect example. So I'm hopeful, we're only in year one of this administration of, the MAHA movement, Make America Healthy Again. And maybe we'll start hearing more about this and getting women to get access to something that could be very helpful to them down the pike. All right, moving on. The one big beautiful bill is almost a month old, and already we're getting flack about what's going on with it. This was really surprising. Senator Josh Hawley from Missouri has introduced a bill. I don't know if we could pop that up, or actually he's got a news release. He is trying to get rid of Medicaid provider taxes. Now, this was one of the few reforms that just seemed to be a no-brainer because it's been dubbed a Medicaid money laundering scheme. For those who are not familiar, the states would game the Medicaid reimbursement system and charge providers a tax that they could then submit to the federal government for reimbursement. And then they would return this money back to the provider. And it was up to, oh my goodness, it was generating millions and millions of dollars for these states. And so under the One Big Beautiful Bill, they're going to limit this now to, I think, 6 or 3%. I think it's maybe 3% in Medicaid expansion states. If you're not one, like Texas, you can do it up to 6%. But in any case, there was the hospitals have come to really rely on this money. And of course, they're all crying broke that this is really going to devastate them, and especially those in rural areas. That's why Hawley wants to get rid of the provider taxes. Now, the One Big Beautiful Bill did include, I think it was a $50 million. I've got to look. Can't remember, but I think it was 50. He mentions it in his, I just want to see. I think it was like we spend, so 100. Okay, so we set aside $50 million, $50 billion for rural hospitals so that they would not be buried by this new reform on the provider tax. He wants to increase that to 100 billion. Devon, do you have any thoughts about why rural hospitals struggle? Other than the obvious, they're not largely populated.
Well, that's the problem. I mean, it is obvious. Rural hospitals struggle because everyone is moving away from the farm. I mean, I did it, 40 years ago? I grew up in a rural area in a farming community, and like all the other, upwardly mobile, or most of the upwardly mobile high school kids, we left. We went to college. We never came back because, the day when agriculture required 20 or 30% of the population's gone. Now it requires maybe 1 or 2%. And so what you have left is older people that retired in the country. You have people that never went to college, and maybe they stayed, or maybe they didn't. Maybe they went to the bigger regional town of the city. I mean, my county, which is way in the very corner of western Kansas, we actually have to subsidize the local doctor, the physical therapist, the nurse. There's a nursing home owned by the county. There's the hospital owned by the county. The if you can call it that, the medical office building is basically owned by the county, and doctors are probably only one, have free rent. My county Old County has to spend, a significant amount of money to keep healthcare services available, and they're real rudimentary. It's not like it's super high tech. For surgery, you still go to a regional town 100, 200 miles away. And there's no getting around that. I mean, we can't have top quality hospitals in every single county in the middle of nowhere simply because there's not the skills available. I mean, no doctor wants to live in that little county.
Yeah.
Sorry, but I didn't either.
True enough. I mean, when we look at this, we have to look at the resources that are out there, and we do have a provider shortage, a doctor shortage. And so, why not put them into healthcare centers where more people could use their services? If you stick them in a rural area and only can reach, a handful of patients, that just doesn't seem to make too much sense. The other thing, too, is, rural hospitals were probably needed decades ago when we didn't have the technology and the transportation that we have today. So it's not that difficult for someone to get to a major trauma center if they need to, or a significant hospital to get better care, that we didn't have, 20, 30, 40 years ago. And, we could have ambulatory hospital units. I know we don't really have those in my state, but I guess they do have quite a few of them in Texas, where you could set up something that would just kind of stabilize somebody. Mm-hmm. And then, you can transport them. We're using helicopters to transport really needy patients. But, there should be no reason why people can't get the best healthcare, but we certainly can't set up shop every 200 miles. It just doesn't make sense.
Oh, yeah, absolutely. Something else that happens in my old county is that a specialist will travel around, like they may, well, like for example, you've heard of Dodge City, Kansas. A specialist from Dodge City may have a office hours in another town on Tuesday, and maybe another town on Wednesday, and the doctors all kind of come together so that a specialist will be in another doctor's office one day a week or one day every other week. So, and if you need a cardiologist, you may be able to see a cardiologist without traveling, but or it could even be by telemedicine. But that's a problem. The problem of rural hospitals being low on resources is not one we can solve. It's, we can use technology, but like you said, we can't, the doctor does not want to live in a little small town in West Texas, most likely. Some do. And in fact, they get better pay because most don't want to live in a little small town. They want the bigger amenities and larger cities. But you're right. And sometimes it means you do have to travel. When my father had his terminal illness, he went to the hospital. They ran a simple x-ray. They kind of sort of had an idea, and then they called the air ambulance.
Yeah.
And so, he flew 200 miles to a bigger town.
Yeah. I mean, we're going to set aside $50 billion now to make up the loss from provider taxes. And it just seems to me foolish that we would be pumping this into an inefficient way of delivering healthcare. Maybe take that money and set up free housing in big cities so rural patients and their families can live there and get better care. That to me seems like a more efficient way to deliver service than to set up a whole other operation that's really not sustainable. I just
you have to also wonder. I mean, how are they going to use that $50 or $100 billion?
Yeah.
Are they going to pump it into local hospitals just to do the status quo, or are they going to look for, or is there an incentive to look for a better way of doing it? Kind of like what my county was doing with doctors that make the rounds. They'll be in a different town every day. And if you're in Stanton County, for example, it may be one day a month that a certain doctor's in at the local clinic. And so, there are smart ways of doing it to increase access to care. And we need to look for smart methods, not just pump money into a 60-year-old building, operation that you wouldn't want to have surgery there anyway, because, it's not the latest, greatest technology available.
Yeah. I mean, I get, Senator Hawley probably is getting a lot of people calling him in his state of Missouri. I don't think of Missouri as a totally rural area. I think of Wyoming as being an isolated, very rural, difficult place to travel in and out. So I'm kind of surprised it's coming from him. I'm sure the hospitals are happy about it. And, we'll see, I guess, it's not going to be part of the reconciliation package, and it's going to have to go through the House. And so I don't know whether that's going to have any traction or not. The other thing related to the One Big Beautiful Bill is, of course, the changes made under Medicaid to cover people who are legally in the country. And there was an article that came out. I want to pull this up because it was pretty interesting. It raised a big issue. So ICE, of course, is now enforcing immigration law and deporting people who are not legally in the country. And one of the things that came up is, of course, Medicaid. Many enrollees are now getting health care, or many of these illegal immigrants are getting health care through the Medicaid system. And there was nothing ever in the law to provide full course Medicaid for people here illegally. There were some provisions up until this point for emergency care in like high immigrant areas like California. But of course, now we turned it upside down, especially over the last 4 years, and it is a huge drain on the Medicaid system. So what ICE has been doing is trying to get, according to this article, there's a lawsuit, and states are suing ICE, 20 states, to stop ICE from using Medicaid rolls to determine whether somebody is in the program legally or illegally. And they claim that the laws protect privacy in the program, but do privacy protections extend to people who are here in the country illegally? Good question. We've got, and I've also heard discussion that this is almost going to be impossible to enforce in Medicaid because, it's going to be up to the states to determine who is eligible in the program, and they're going to have to enforce it, and we're going to have to monitor them and watch it. I've heard this is so extensive that it's just going to be impossible. But, under the one big beautiful bill, these states risk getting Medicaid funding if they don't enforce Medicaid enrollment, proper enrollment. You have any thoughts on this, Devon?
Yeah, I mean, you need a way. I don't know if ICE is the right ones to enforce Medicaid, eligibility, but you definitely do need somebody to audit Medicaid eligibility to make sure that states are not just quietly slipping in people and expecting the federal government to pay 80% of their healthcare bills. Because, as you know, the Medicaid is a federal-state partnership with different pots of money for different eligible beneficiaries. Expansion states get, I want to say it's 90% federal match, whereas a wealthier state for just the traditional Medicaid enrollee would get maybe 50%.
Mm-hmm.
That's, of course, also why it's so important to not allow the provider taxes, as states need to pay their fair share. And if a state wants to pay the cost of illegal immigrants, that could be their priority or their prerogative, but don't try to pass that cost back on to the federal taxpayers, because that's not the deal. I mean,
Right.
The deal is whatever you've negotiated with the federal government. But so, yeah, we need to have some mechanism to audit the Medicaid rolls to make sure everyone who's enrolled is eligible. That I'd be I'm not sure if ICE has the skills to go. And like a lot of people, I do worry about the privacy. I mean, I don't want my medical records to be pulled by HHS just to make sure that, I'm here illegally. There is HIPAA.
Right.
But at the same time, it's a problem we do need to solve.
It's something none of us can avoid, because we're all going to end up in Medicare, and the government will have our health records, whether we like it or not. The question is, do you feel like your privacy is enough of a factor to protect whether you want to join Medicaid or not? I wouldn't trust it, actually. I wouldn't trust it. Now, there have been reports that states use Medicaid rolls and sell these lists to political organizations to try to get people to vote a certain way. There's nothing really protecting that data. And, if there was such a concern about privacy, why don't we just allow people to get a fund that they can spend and buy their own health care and not have to go through a big government system? I mean, we've talked about having, cash accounts or bridge cards for low-income people to be able to use in healthcare. That would seem to protect privacy a little bit better than, having them thrown into one big system. But it's funny, now that we have illegal immigration, we're trying to enforce immigration laws in the country. And now all of a sudden, privacy is a big worry, big concern. So I don't know what the solution is here, but we will see how this unfolds. Next year too, it's going to come up again, because we have Medicaid people. We're now requiring Medicaid people to work, able-bodied individuals to work for benefits. And we're going to have to figure out ways to enforce some of this. And you mentioned something earlier about Texas and the reimbursement rates. And Texas is not an expansion state. So their reimbursement is a lot lower than those who've expanded their programs, who get like 90 cents on the dollar. You guys, I think, get 65 cents for traditional Medicaid enrollees. And it's very irritating to states like Texas because, you're California, which maybe has 50% of their people in their Medicaid rolls who are in the country illegally. And Texas, why should they have to subsidize 90% reimbursement for a state that doesn't want to enforce immigration? So I just don't know what the solution is, but I guess we'll see what happens with these lawsuits and whether, they change anything regarding Medicaid privacy. All right, last on our list is a blog post that you wrote recently on doctors, medical doctors, and whether physicians view their job as a calling or a job. And I don't think this would have ever been a question several decades ago, because I think to be a doctor is a calling. It requires a ton of time, money, effort, skill to become a good doctor. And so you really have to have a vocation to want to be a doctor to do it. Today, I'm not sure if that's the case. And I think it's likely because doctors have really been made to feel like cogs in a system. They're usually employees of a hospital. They don't have that kind of relationship with a patient that they used to have. And so maybe they do view their jobs differently. What did you write about here, Devon?
Well, I started out my blog post because I had a conversation with the medical director of the telemedicine firm Teladoc, years ago. And he was an old school physician. And he was just lamenting how back in his day, medicine was a calling. It wasn't a business. You were a professional. You knew your patients. You knew, you cared for your patients both, emotionally as well as physically. And that's not the norm anymore. Well, the reason why that has changed is because doctors increasingly went to work for the hospital. They went to work for hedge funds. They went to work for private equity owned group practices and became, like you said, they became a cog in the healthcare money-making machine. And they get a salary. They may or may not get, I don't know, what's the financial incentives to, and the way they practice medicine becomes governed by, their employer. Becomes governed by an MBA in the C-suite of the hospital. And what's funny is that the old doctors say medicine is a calling. The young doctors say no, it's a job. And the young doctors are they get irritated, they get offended when the issue is raised that you should consider medicine your calling. Because young doctors feel like that is just a code word for the hospital is going to abuse you and make you work 60 hours a week and work weekends and work evenings to make more money. So,
right. Well, you hear younger doctors talk about a work-life balance where you would never have heard that. There's always been a kind of a trial system to become a doctor as you're a resident and you work untold hours to train. And the only thing that got young doctors through that was to know that someday that they would be on top of the totem pole and a younger doctor would be filling in on those crazy hours for them. And I just don't know. You look at today's doctor and they graduate from medical school with untold debt. And so they're concerned about that. And then, again, most doctors now work for a big system or company, and they don't have the kind of relationship that they used to have with patients. Mm-hmm. And, it's if you love your job and you feel that it's your mission in life to be a good doctor or any profession, right? 60 hours a week wouldn't bug you. But I think we've made medicine into such a assembly line kind of venture that people have really lost heart, which is too bad. I hope this changes, I think if we give doctors more opportunity to explore new healthcare models, people who work in direct primary care love it. They wouldn't mind working 60 hours a week because they're not dealing with all the hassles that physicians working for these large conglomerates have to do. You know, they don't deal with insurance companies, and they can spend time with their patients. So we'll see what happens.
Well, I think a couple other items are at play too. I've talked to physicians, and I heard from one physician that said 50 years ago, your doctor was probably a middle-aged white male. He had a wife and family, and the wife may or may not work, you know, back in 1975, if, you know, she was married to a doctor. Well, nowadays, half of medical school graduates, in fact, I think 51% maybe, are women, and they're not willing to put up with 60 hours a week. Plus, you know, back in the day, let's say 1975, working the extra hour, you know, after say 8 hours or 9 hours, was all, you know, the revenue was almost entirely profit, you know, because you've paid the overhead. So yeah, you work 60 hours a week because, you know, the difference between working 40 and 60 might be doubling your pay. Well, nowadays it's not going to double your pay. It's going to increase it by maybe, you know, 30, 40%. Well, doctors are just saying, especially, you know, women with kids at home, hey, you know, I don't, you know, if they're married to a doctor as well, if it's, you know, it's like, we don't need money badly enough to sell our home life and our kids, you know, future, you know, parenting for a few extra dollars. And they're like, no, I'm not going to work insane hours, you know, and they still work long hours. I mean, the average is still close to 60, but you know, the evenings and weekends, no, they're not willing to give those precious hours away to their employer just for their employer's benefit or their employer's convenience. And
Well,
you know, of course, doctors are rare, so they have the leverage.
I think you're right. And they have to make a judgment call. I can name, I'm not going to do it on this show, but 5 people who are working as part-time doctors, young doctors. And my thinking is, I knew one person who left altogether in the in their mid-30s, didn't even live out their career. And I'm thinking, how do you do that? You put in all that time, all that money, all that effort, and you're not working in your profession. And I just think that, you know, we've gotten to this point where practicing medicine is not what it used to be. And so we're going to start seeing more of this. I don't know that that's really beneficial at all to the patients. And doctors aren't too happy about it either. So who knows? All right. We are going to have to end it on that point. We've run out of time. Be sure to check out healthcare news at heartland.org on the website there, and Devon's healthcare blog at the Goodman Institute Health Blog. We'll have links in the podcast notes for that. Both of these publications can give you a free market perspective on the very latest in healthcare news. In the meantime, stay well, stay safe, and we'll see you back here in a couple of weeks.